Good morning, everybody. And it gives me great pleasure to welcome you all to the very first ever dedicated Pharmacometrics Africa conference. We are in the room here in Kampala at the Infectious Diseases Institute on Makerere University. And I know that there are delegates online from various places, and I'm sure we'll be hearing more about who you are and where you're dialing in from as the day progresses. Some of us have been here for several days. We're just coming fresh from the Digital Health Africa conference, but this is a totally different event. This is Pharmacometrics Africa, and it's a celebration of everything that's happening in pharmacometrics on the continent. So we've tried to make it as interactive as possible. We're going to have a range of speakers. We have posters, which are both physical in the back room and also online. There's going to be plenty of time for interaction. And I think we all know it's the people that make conferences really, really flourish. So we look forward to getting to know you all and hearing from all of you. We will be doing more housekeeping announcements as we go, but I would say simply that there is plenty of water. So please, if you need any water, there should be some outside, and coffee. Posters and things are in that back room. And apparently I misdirected people on Wednesday to the toilets and sent them on some kind of wild goose chase. But if you do need to just go out, then turn right. The gentlemen's are then on the left and the ladies on the right. And it's the same on every floor going up. I think that would.
Those of you that are online, the toilets are where you normally. So, Katrina, maybe I take the opportunity to also welcome our online delegates. There's about 12 of them at the moment. Katrina, you can't direct them incorrectly. So, welcome, online delegates. We really would love this to be as interactive a meeting for and a great experience for you online as it is for the people here in the room. I know a lot of you would probably have FOMO. Uh, it's a word that you'll see crop up soon as well. But I'm going to show some slides right now just to tell you how you'll interact with us. So here it is from my side. Add to the welcome from Katrina. This is the Pharmacometrics Africa conference. We are talking to you from Kampala, Uganda. For the virtual delegates, you're probably very comfortable with using these technologies right now. So the chat function, please use it to say social stuff like where you're from, why you're so excited to be here, etc. If you have a serious question, then rather use the Q&A function. Not rather use, please use the Q&A function. I'll keep reminding you about that all along. What will happen is that the dedicated virtual chair, that's me for the moment, but I will soon be joined by Veshni Pillai, and we'll introduce her when she joins us. One of us will then pose your question on your behalf to the speaker in the room. For the people here in the room, the rule is that you must wait for a microphone before asking your question. If you don't, then the people on the webinar, on the virtual platform, will not be able to hear you. There's an active social media campaign because you know who our champion of social media is. The hashtags are shown on the screen right now: PMXAC25, Pharmacometrics, or you can say PMX Africa. Those are the social media. Please go wild with that. We actively encourage you. I think the last slide is, oh yes, and then Katrina just mentioned the posters. So there's physical posters printed here in Kampala, but those posters are beautifully laid out on the platform, and please go there as well. Katrina, back to you.
Thank you very much. And as I always say to everybody I speak to in meetings, is that there is really no such thing as a stupid question. So if you have any questions about how to interact or the logistics, for both those in the room, but also those online, please do just reach out. It's an honor to be standing here in the Infectious Diseases Institute in Kampala. Whilst I'm a professor of clinical pharmacology and global health from the University of Liverpool, Kampala has been my home for the past 11 years. like many people like myself who end up in places, I initially came for 4 years, and one grant led to another, and the work really took on a life of its own. And one of the absolute highlights has been the sort of establishment of Pharmacometrics Uganda, and we'll talk about that a bit more as we come. But we also have really strong support from our organization, and we felt it was only appropriate that we have some strategic remarks from Tom Kakairi, who is our head of strategy. He is standing in for our executive director, Andrew Kambugu, who has travelled, but Andrew is actively involved in all of our activities and very excited by everything that's happening here. So Tom, the floor is yours.
Good morning. My name is Tom Kakaire. I head strategy and development. Some of you were here when I introduced myself for the DHA. I'm glad to see so many bright and eager faces this morning. As Catriona mentioned, I'll just make a few brief remarks on behalf of the senior management here at IDI, and specifically the ED who has traveled. It's a great pleasure to welcome you to Pharmacometrics Africa. This is a landmark conference. Catriona has made that very clear to me. And we are really honored to have you here. And we really, really appreciate the choice of IDI as the hosts. We don't underrate that achievement. We're really proud of being the host of this landmark conference. And it is good to see all these change makers, all these scholars, many of whom I've heard about. I remember a few years ago, not a few actually, quite a few years ago when I first heard about pharmacometrics, even the discipline. And the name Colin Pillai at that time, in my mind, became inextricably linked with this discipline, especially in this part of the world. So I'm glad to see Colin and so many other faces that are really at the center of this discipline in the region. So once again, welcome to IDI and Makerere University. Makerere University, as you might know, is a centenarian. It made 100 years a couple of years back. IDI itself made about 20 years a few years ago. And I mentioned that because the theme when we celebrated 20 years was celebrate the past 20 years, inspire the next 20 years. And as you have this conference, I think it is a very fitting theme that we can borrow from, because I think it will serve the purpose of igniting a collective vision for this discipline across the region for the next 10 years. So again, the organizers and conveners, thank you so much for choosing IDI. I would also like to thank all the sponsors and partners. I think they were on the screen, they are not there now. We do not take for granted the support that has enabled this conference and so many things around it to happen. And allow me here to just point out one particular partner who has really taken this field very far, at least here in IDI and probably in the region. Dan Hartman and the Gates Foundation. We are really grateful for the support and the obvious good work and really impressive results that we've seen coming out of here and many other places. Here at IDI, our mission is around strengthening African health systems. And this growing community of pharmacometricians really speak to that mission. The tools and skills that this group has and many others a group that is really growing in size and stature. They're really transformational tools, and they translate directly into health outcomes, into lives saved, and a lot of the people who are associated with it. Catriona is one very good example. I'm really passionate about not just the science, but where it leads us, what the impact of that science is. So this, as Catriona mentioned, there was we were privileged to host DHA, which has now kind of morphed into Pharmacometrics. So in Uganda, one of the common languages, Luganda, a father to twins is called a Sarongo. So I feel like we are Sarongos this week. And I would like to say, I think the Narongo really, the person who can claim the Narongo position really is Catriona here. So Catriona, thank you so much. And the entire group that has made this possible. I especially want to acknowledge the conference's focus on underserved or populations which are vulnerable, women and children. I think, and Catriona is again very, very passionate about that. I think for those populations, some of the work that you're doing really translates into, integrating them and meeting their needs better within our health systems. And then the talent in the room. We are so proud to have you here. I have been told again and again that this is probably one of the most productive groups of, Catriona likes to call them geeks. So allow me to say that. And I say that with pride because, as you know, geeks have taken over the world now. We are looking to them to solve many of our problems. And that is not, and Pharmacometrics is one of those tools that I think is really, has the capacity to be transformational in meeting the unique needs of our continent and our region. So as we dive into the conference, I just want to say, please take the opportunity to share widely, to collaborate, to co-create new ideas. Certainly at IDI, if anyone picks up something that we might want to collaborate on, my office is responsible for making those collaborations happen. And Catriona knows how to reach me. So please reach out and let's see how we develop this field further the next 10 years. Welcome once again to PMXAC 2025. And I wish you a very productive conference. Thank you.
Hello, everyone. This is just a quick message from me to welcome you and to share how excited I am about the first Pharmacometrics Africa conference. Sadly, as you can see, I could not be in Kampala with you in person, and I am very much aware I am missing out, because this is a big milestone for Pharmacometrics Africa. This conference builds on the momentum from WCOP 2022 in Cape Town. I am sure many of you in the room were there as well. And it shows how far we have come in establishing a strong and vibrant African pharmacometric community. As you know, the core mission of Pharmacometrics Africa is to expand and strengthen pharmacometric skills on the continent. This is why, with the help of many of you in the audience, we have created many learning and training opportunities for aspiring pharmacometricians. To capitalize on all these training efforts, however, and to ensure that our impact is long-term, we also focused our efforts towards fostering scientific collaborations, both within Africa and globally. Colin and the organizing team have done an amazing job bringing together to Kampala so many stakeholders. And this is why I'm so excited about this meeting, because it's the perfect catalyst for the magic to happen. All the right ingredients for success are there in the room. Smart, budding pharmacometricians, clinical researchers, funders, Now, we just need your help. Have fun, share your science, connect, and explore the synergies that will unlock the true potential of pharmacometrics in Africa. While I'm not in the room with you, some of my team members are there in the room, so I'm sure they're going to fly high the UCT flag. Please do connect with them. I'm looking forward to hearing from them about the conference, the people they met, and the achievements. Until then, I am sure I will get extensive social media coverage from Catriona, who is probably already tweeting as you speak, and she'll make sure to feed my FOMO. Anyway, I wish you all guys a fantastic conference. I am very jealous. I really hope this is going to become a regular fixture in the future so that I can make sure that I don't miss out next time. Enjoy the conference, everyone.
So in the meantime, my co-virtual chair has joined me on stage. Welcome, Veshni. Veshni, if you could just say hi and welcome everybody.
Hi, everyone. Welcome to our first inaugural conference and welcome to Kampala. I hope you have loads of fun. Enjoy sharing the science.
Great stuff. So as we mentioned earlier on, there'll always be a virtual chair, or in this case right now, it's two virtual chairs and a face-to-face chair. We're moving into the first session, the session that will then cover the history, present, and future of pharmacometrics in Africa. And the physical chair, the in-person chair, is Babatunde from our Nigeria chapter. Babatunde, let me hand it over to you.
Thank you, Colin. I'm Babatunde Adeagbo, an associate professor from Obafemi Awolowo University in Nigeria, and I lead the Nigerian chapter of Pharmacometrics Africa. The first session here today is laying a foundation for the rest of our discussions for this conference, and it's outlining the history of pharmacometrics in Africa, where we have come from, the progress we've made, and the challenges ahead of us. Our discussion will turn to what Africa needs to leverage on this field, exploring how we can attract and, most importantly, retain the brilliant talent on our continent. We have distinguished speakers who have been strategically selected to look into these topics. In this section, we have three presentations. We will provide detailed look into history of pharmacometrics, the future of pharmacometrics, and we selected three presentations on careers in pharmacometrics to offer guidance and inspiration for both emerging and established professionals in the field. Therefore, I would like to introduce our first speaker. I don't need to introduce her. We all know her. She is our champion, a professor of clinical pharmacology and global health at the University of Liverpool. She has been here for the past 10 years in Uganda. She's leading the Maternal and Infant Lactation Pharmacokinetic Center at the Infectious Disease Institute at Makerere University. Our work focuses on understanding the safe and effective use of medication in complex and older study populations, such as pregnant and breastfeeding mothers. She is a passionate mentor. She's the leader by excellence, a dedicated advocate for public engagement, the champion of public engagement in pharmacometrics. She is the capacity building person in research and also leads the Uganda chapter of Pharmacometrics. Everybody, online, in person, join me to welcome Professor Catriona Waitt.
Thank you. Wonderful. Wonderful. Well, thank you for that introduction. And I actually quite like the title Nalongo. I think I will keep that one. I have been called Nalongo many times, but sometimes I get Jaja, and I prefer Nalongo. It's a great honor to give this talk. And I think one of the challenges about giving any history of anything is history itself is always going to be limited. It depends whose perspective it is, who's telling the story. There's always going to be biases. There's going to be things that were really significant to some people that are left out and other things that are maybe overemphasized. So I want to sort of almost start by the caveat of saying, well, anything I say is what I've drawn together. But another thing is, whose story is it to tell anyway? Because we are all in the room, we all have many, many stories. And as the Nigerian author Chimamanda Ngozi Adichie said, that the danger of telling a single story is that it makes it sound like it's the only story. And what I'm hoping that this conference truly is a celebration of all the stories that come together. And as you will see as I go through, many of you have actually helped me in preparing this presentation. When I first thought about history, when I was first given the assignment, I thought what I'm going to do is I'm going to kind of do almost like one of those collateral histories. I'm going to look at what's happening in the pharmacometrics world outside of Africa, and then sort of show what's happening within Africa at the time. So as you know, pharmacometrics became a discipline really in the late 70s and early 80s. But I could actually find very few people who would even admit to having been alive in the late 70s. But thankfully Bernd Rosenkrantz and myself were. But some others perhaps in the room too. But by the sort of, I don't know, mid to late 1980s, there was some wonderful work going on in Durban by some brilliant young minds. And you have to remember, this is 1988. I mean, what kind of computers, what kind of software existed in 1988? And there is also a question for you, okay? Audience participation starts now. Which one is Colin Pillai? Is it A or is it B? So please, can I have all votes for A? Okay, and votes for B. Well, okay, so the B seems to win, but I think those of us who have been here for the last few days know that this is actually Colin Pillai. Anyway, I'm going to fast forward somewhat to sort of the early sort of 2010s and what we started to see around that time. And this is where some of you actually are within living memory, that we started to have short courses. We started to have experts from other parts of the world who came to Africa to lead courses. And you'll know some of the faces. I know, could you raise your hand if you were in Kampala in 2012 when Joel Owen and Enunciating came down? Yep. So Alan, yep, you Innocent, you were there. Who else was there? Yeah, exactly. So it was Aida too. It was quite an influential meeting that these experts from other parts of the world came, they gave their time, they gave their resources, and they started to mentor this new generation of researchers. Because obviously there was a lot more happening in South Africa, also Tanzania, I believe Ethiopia, and I may have missed some out. And all of this started to come together with the actual official launch of Pharmacometrics Africa in 2018. Now, this was a Gates-funded initiative that aimed to really address the problem that we were having, which was the training and retention of pharmacometricians in Africa capable of responding to local priorities and capable of actually getting African relevant data, African relevant products onto the market. Also, one of the aims of Pharmacometrics Africa was to support the World Conference on Pharmacometrics, which Paolo has already mentioned, a real milestone event. It was delayed slightly. I can't remember. Was there some sort of virus or something happened in 2020? Anyway, but that was a massive milestone event, but also importantly, it opened our eyes to the way hybrid conferences could be done. And I think, as many of us will see, COVID brought many opportunities as well as its challenges. So again, I'm aware when I stand in front of an audience like this, you know this, but why do we need pharmacometrics in Africa? Why? And it's because our populations are just so different. We're the most genetically diverse population on Earth. We have different diseases that are endemic, diet, nutrition, socioeconomic factors, also some deep-seated cultural beliefs, use of herbal medications, and from my perspective, also the high fertility rate and prolonged breastfeeding makes this population really quite different to what you're seeing in other places. Now, you could say that doesn't mean we need to do pharmacometrics here, but as you know, when you're looking at data and you're trying to interpret what's happening, and you're trying to work out whether something's actually a blip or an outlier or an error, or if it is genuine, that's when we need to understand all of this. And there are also many of the health systems factors. And I know that some of the team in the room are fresh from a regulatory workshop in Pretoria, which took place whilst we were having the NL Mixer pre-conference. But we have different medications that are available, sometimes where we have more of a public health approach to policy, a kind of everybody goes on the same medication rather than personalized approaches. We do have other issues, including substandard and falsified medications too. And there has been generally a lack of clinical trials in Africa. So at DHA, we were able to hear from Adrian Kruger, who runs the Clinical Trials Network, and he showed the expansion of clinical trials that are taking place. But there's a real need for more early phase work to take place here. And that's something I look forward to discussing more in the next few days. And it's the complexity. So it's not hyperbole to say that this is a pregnant African woman, and it won't surprise you that she's living with HIV and she's on TB treatment. Last week, she had a bout of malaria and she had postpartum sepsis. That doesn't surprise us at all. But with epidemiological shift, she's also got hypertension, type 2 diabetes, and she does have depression, which is increasingly being recognized and treated here. But that is not all. She's living in a region of the world where the neglected tropical diseases are rife. And if you speak to Francis Ojara over there, only 1/5 of the WHO recommended treatments for these conditions have data to support their use in lactation. And not only that, the threat of outbreaks. When you watch the news at some point, you'll realize that DRC declared an Ebola outbreak yesterday. It's okay. It's not any of the border states that usually are affected. You are fine. But the fact is, this woman is living in these areas where she needs access to vaccines and therapeutics. And if we do not do these studies because we're scared of doing trials in pregnancy or breastfeeding, or we don't understand the complexity, she will die, her baby will die, lives will be lost meaningfully, and she will actually be protected to death. And that is not just something I say. It's actually the title of a systematic review, but it is true. You know that, and you'll talk to my team members about that more. But coming back to Pharmacometrics Africa, so I think many of you have seen this slide. When I show the different QR codes, they just sort of take you through to the different parts of the website and where you might find more information. But you've seen this slide. Since its inception in 2018, it's estimated that more than 500 scientists have been trained across the continent. But as you know, Africa is far from being a country. And this is where it gets really exciting, and this is where it involves all of you in the room, because chapters started to spring up. So the first chapter, and I mean, calling it a chapter of Pharmacometrics Africa is actually insulting, because the work going on in Cape Town pre-existed PMX Africa and was actually intrinsic to its founding. But there's been a group there for a very long time, led by Paulo, who has already introduced himself very capably. Can you put your hand up if you've actually passed through Cape Town as a PhD student or a postdoc? Wonderful. Could you put your hand up if you're the head of department of clinical pharmacology in Cape Town? So Pumla Sinkati, who many of you will meet later on. And of course, the main expertise or major expertise is HIV, TB, complex drug-drug interactions. And I think the team hardly needs any introduction. But just a word about Paulo. So, you know, we didn't put a bet on to embarrass each other in our talks, but I met Paulo in 2016. I actually flew to Seattle for the weekend to meet him to write a grant. And it's a bit far to go for the weekend, actually, from here, but we got the grant, and that was virtual. And that was when a lot of things started for us. But importantly, Paulo and I have kind of sort of grown up together academically. We got promoted to full professor the same year. We're going through similar stages in our careers and building our groups. We face similar challenges with funding and collaboration. And what I want to make the point here about is peer mentorship. You need to find that person who maybe even sitting beside you is probably in this room, somebody that you can just actually share some of the challenges and the strengths. But Paulo has always encouraged me to dream. We talk about it as our, I shouldn't say, but we have crazy plans of really just changing the world. And things that seem impossible, he always says, but is it impossible? Let's try. And together, I think we've done more than either of us would have dreamed. And that person will be in the room for you. And one of the things that I thought was impossible was the establishment of the Uganda chapter of Pharmacometrics Africa. Now, it was Paulo, but also a bit of a nudge from Colin. Has anyone in the room ever felt nudged to do something by Colin that they were not pushed? Wonderful, wonderful. So there's going to be certain themes coming out of this talk, but that feeling of you never actually will feel ready, okay? That is normal. But what we did is with the team from Pharmacometrics Africa, we started with an online course that had fully Ugandan faculty, but it wasn't just us. The mentorship given to us by Colin, Paolo, Leon Aarons, and others enabled us to do something that we didn't think we could do. And it wasn't just doing a course because it got us talking together. We formed a community of practice. We started to set vision and priorities. Another milestone was getting the Gates Milk PBPK project a couple of years ago. And that, I believe, out of all of the chapters, our group is one of the first to bring the PBPK techniques into the mix. And we hosted quite a successful workshop in 2024 that many of you were at. We've also spent a lot of time trying to demystify what we're doing to our stakeholders, and that's where the community engagement comes in. We also have a monthly webinar. Some of you in the room have already spoken at. And what we try to do is get an expert to come and really showcase an aspect of pharmacometrics that applies to our setting. Our next webinar is next week. Our speaker is in the room, Francis, and the QR code is for registration. Shortly afterwards, and this is where it just really starts to accelerate, shortly afterwards, the Kenya chapter was established in 2023, but it's been discussed for quite some time. Is Bernard Zagutu in the room? Yeah, wonderful, wonderful. I hadn't seen you yet this morning. You're most welcome. Bernard Zagutu is one of the key people in Kenyan pharmacometrics. Who else is Kenyan in the room? Who else is involved in the Kenyan chapter? Yay, there you're. Colin. And some real milestones of actually establishing an MSc in pharmaceutical product development via Strathmore, and that's a really exciting thing. We must talk to Bernards about that. Then the next one was Stellenbosch. Veshni is on the call, and whilst Africa is not a country, Cape Town in that respect is not a city, because the Cape Town group and Stellenbosch have quite different interests and strengths. And this chapter was established when Ahmed Abou-Fatih completed his PhD. And one of their milestones was hosting DHA last year. It's interesting to note that the faculty is mainly APT alumni. And again, another theme, being pushed by Colin, being involved in APT. And Cassius is going to be taking up a postdoc fellowship. The group is starting to really mature, and you can see the identity with their new office space. Then next, Nigeria. Who's from Nigeria in the room? Nigeria, yay! I think, can I be Nigerian today? Do you think? Yeah, I'll be. Yeah, okay, I'll be Nigerian today. So many from Nigeria in the group. So again, activities had been going on in Nigeria for some time, and I always have to show this photograph involving Paolo and Leon Aarons at a Monolix workshop several years ago. But Babatunde is our lead. Ochuko, who's in the room, she really felt the calling to do this after the APT program. And they also have monthly webinars. Nigeria have done an amazing job at almost getting every African, every Nigerian kind of diaspora that's involved in pharmacometrics to contribute. And that's a beautiful community of practice. Next, and very excitingly, and you'll be hearing more about this, is Tunisia. So for a long time, we were aware that we were focusing on the historically Anglophone, I hate that word, I think we all do, but we were the English-speaking African countries. But that changed when a workshop took place in Senegal, and Noor Chaba, another APT alumnus, set up the Tunisia chapter. And again, it has its own distinct flavor, different priorities, different needs, different collaborations with local faculties. Like Uganda, they started by doing a course, and there's an interesting paper that has just come out about language in pharmacometrics. The picture at the bottom, I don't even know what side for you it is, but that shows Sonia Kerr and Miriam Al-Galul at the PBPK workshop last year. So again, it just sort of shows how we're really building that network within countries and within the continent. So APT, what is APT anyway? I must confess, I find it confusing because I'm involved in the APT sepsis, which is the active prevention and treatment of maternal sepsis trial, but that's not it. It's the applied pharmacometrics training. If you're a current APT alumnus, not alumnus because you're current, if you're a current APT fellow, raise your hand, please. Yay, you're here in the room. Okay. If you're a former APT fellow, right, so I think that's at least 50% of the room, and that indicates how transformative this was. There was a need for that actual upskilling and building those career opportunities. And the APT fellows, there's a full publication that is here. I ran it through a word cloud. I find that a very powerful way of getting key themes, and that's what the map represents. But basically, this was launched in 2021 in partnership with Satara, and we really target kind of late doctoral and early postdoctoral pharmacometricians. We see it essentially, we started informally to call it as a finishing school. The fourth iteration is underway, and it's competitive. It's competitive and it is intensive. And so what we do is we select competitively, and then there's a sort of midway point where the most successful candidates are selected to go into this deeper immersion program, where they work in pairs or small groups with industry partners and do a project to industry standard. But more than that, there's a lot of kind of soft skills, mentorship, coaching, face-to-face workshops. There's a huge amount. So if you don't know about it, speak to anybody in the room and they'll tell you how awesome it is. 27 alumni and 10 more in the pipeline. I thought it was nice to actually hear their voices. So the current APT fellows wrote me a paragraph. And in contrast to the previous word cloud, here we have words like dream, ambition, confidence, gained, personally. So it's the fact that, yes, this is a hard skill, but there are the softer skills, and it's actually people's lives that are being transformed. And Colin and the team, I think we cannot thank you enough for the work and the vision that you've had. So as I move in towards my conclusion, when I wanted to present the initial history, I thought of it as being a linear thing, but actually, like many histories, it divides into sort of ages, like the Stone Age and the Bronze Age. And I would say that before 2010, what we really had was visionary leaders. We had individuals and small groups, and we had some really great work that was going on, but it hadn't quite kind of caught that momentum and that sustainability. And then in the sort of 2010s, we had, again, the visionary leaders, we had more short courses, there was some digital transformation taking place. And I think that's the thing that we need to also think about the context here. I don't know, can anybody remember their first conference call? I can tell you exactly when mine was. It was 2012. We were writing the Dolphin 1 protocol. I had 2 toddlers and a baby, and that's where it got complicated. But I had not done a conference call until then. I got my first smartphone in 2019, basically so I could communicate with WhatsApp and things. I was really late in picking up on these things, and I feel quite shamed by some of the AI talks that we've had in the last few days. But the fact is, this increasing computational power, I mean, who's done runs that you had to leave your computer running for like days and then it would crash or there'd be a power cut and all of these things? But things are getting better, and the internet availability and speed. And actually, COVID gave us a bit more of a push to this hybrid working and networking. So then comes 2018 with the launch of Pharmacometrics Africa, and that's where we really start to see these networks, the continuity, the digital transformation. And it was almost like rather than being linear, very much an exponential growth. And that kind of leads us into the sort of past 5 years, the history that many of us in the room have been a very key part of, where we have these regional hubs, we have the emerging leaders, we have the career development, but also the different hybrid career options. You're going to be hearing from Aida and some colleagues in a little while. There are quite a few people that are finding ways to have jobs that are maybe partly industry, partly academia, or have some consultancy, so flexible, diverse careers. And again, I would encourage those younger ones in the room, speak to the people that we talk about, because there are options that probably weren't possible several years ago. And I believe that all of this leads to sustainability. So in a moment, I'm going to hand over to Steve Kern, who's going to take us into the future. But to me, the future is African-led trials, focusing on African priorities, at some point with African funding, developing African products that are based on African predictions. And the exciting thing about talking about that is this is going to happen through the collaborative effort of everybody that's in the room today. I am aware with an acknowledgement slide, I will miss somebody out, but thank you. I think just about everybody in the room has contributed to my talk, because it's rather than being a history, it's an ongoing story, and you are all part of it. Thank you very much.
So thank you, Catriona. So Catriona, I know that you've already announced that Steve's going to come up next. I'll give that back to Babatunde in a minute, but Veshni and I wanted to just update you on an important component of recognizing the excellence that's going to happen within this conference. So we have some poster awards, and there's two broad categories of poster awards. One is a set of poster awards that has been judged by a group of experts that we'll describe to you a little bit later. But there's one time-bound activity that Veshni will tell you about right now. Veshni?
Great. Thanks, Colin. I think before I go to the post-event evaluation form, I must express that all posters have been uploaded onto our website. So please have a look at them as well, and take full advantage of our poster session as well. So on another note, there is a post-event evaluation form. This is where we learn from our experiences and we improve the next time round and try and get you more comfortable. So if you could please scan the QR code, which will be posted shortly by our team online or within the day. So please take a few minutes, scan the code, and give us your feedback. We'd love to hear from you. Thanks, Colin.
Thanks very much. And then back to you, Babatunde.
Thank you. In this next session, we are honored to have Dr. Steve Kern joining us virtually. He is the Executive Director of Global Health Labs, an innovation laboratory that works in partnership with Bill and Melinda Gates Foundation. From 2013 to 2022, he served as the Deputy Director of Quantitative Sciences at the Gates Foundation. Previously, he served as the Global Head of Pharmacology, modeling at Novartis Farm in Switzerland. Dr. Kern has extensive experience in model-based drug development and has also been an associate professor at the University of Utah. So in this session, we are glad to have Dr. Kern. You're welcome.
Great. So thank you all. I hope can you hear me okay?
We can confirm that, Steve. We can see you looking sharp and we can hear you very well.
And let me first start off by responding to Catriona's comment. I can tell you that in 1970s, I was very much alive, and my first computer used punch cards and paper tapes as its mode for holding on to your programs. So, all right, I'm going to share my screen, and hopefully that comes up as well. All good? Okay. So I'm going to talk to you about what African patients and clinicians, and you see that asterisk in the title as well, regulators also need from pharmacometrics and pharmacometricians. And this is my perspective based on my experience of seeing pharmacometrics evolve over the last 2 decades, both in the United States and in Europe from my own experience. And I think the key word in this title is need, and really thinking about what those needs are. So I'm going to basically shift that forward. There we go. Okay. I'm going to address 3 needs that I want to highlight in this talk. And I think importantly, from my view, needs create opportunities. And so those needs include essentially the confidence in the science that you're communicating both to your peers and to the patient population broadly. And I think if we can do that effectively, we can build trust in our methods. People can understand what pharmacometrics is and what it's bringing and offering. It's not some magic way of shortchanging the process of scientific development, but actually it's a tremendous opportunity to leverage knowledge and really accelerate the development. But that trust is under real siege right now, certainly in my own country, around science and medicine and public health. And so I don't think we can take for granted the importance of that building confidence and building trust. And I'll talk about that with some examples actually from your own continent. The second big need is communication, and really being able to clearly communicate and give good insight of your knowledge and your observations and how pharmacometrics can contribute to improved clinical care. It's really important that that clearly informs the results so that we're not just talking in that nerd speak that you heard Catriona refer to earlier, but that we're actually communicating at a level that both our colleagues and our peers in clinical science who maybe aren't pharmacometrics experts and don't really know what a VPN is or what it means, or don't they really even care? But in fact, really, what does it mean for them in terms of being able to take care of patients better? And then the third need, which also then leads to an opportunity, is the implementation. And how do we use tools? And particularly, you all, maybe many of you came from this digital science conference that was held in Uganda, that was the twin event that was referred to earlier. So how does implementation that can amplify the strengths that exist there in your room and in your own continent, rather than replace? And that's one of the things that I'm very adamant about as we think about the use of things like artificial intelligence. It's not intended to replace capability, it's intended to enhance capability and to basically amplify the strength that already exists in the room, not in some way to make up for a gap in strength. So those are my 3 points that I'll hopefully convince you are important to focus on as you evolve in your career. The first slide I want to talk about is this article that I found really interesting. It was published in Nature in 2017, and it's a Nature News article written by Linda Nordling about the explosion that was happening at that time with putting genomes to work in Africa. And of course, H3 Africa, not H3D, Kelly Chabali's effort, but the genome effort that was led out of Cape Town and is led out of Cape Town was really getting off the ground. And it created a huge amount of excitement and enthusiasm for the potential to understand how genetic variation in the continent could be really informative to bring precision medicine to Africa. But as Linda asks in this headline, will it help? And she opens up the article, if you haven't read it, with a reference to the work of Colin Massamarembwa. And you see Colin's picture down in the lower corner there in his laboratory in Harare. And Colin had published this paper that I listed from the European Journal of Clinical Pharmacology in 2008 about the prevalence of this genetic SNP variant in metabolizing enzymes that really had a key impact on the clearance of the drug efavirenz. And one of the things that Colin noted was that the prevalence of this SNP in the Zimbabwean population is as high as 20%. And that meant that there's a high likelihood that a number of patients were going to be slow metabolizers of efavirenz given standard dosing, and would build up then levels that could actually create toxicity and untoward effects. And Colin brought this science and this information to the ministry in the country, warned them about this as an issue, but actually the warnings weren't really heeded. And it wasn't for a number of years before the insight and the understanding of what Colin knew well in advance actually had an impact on changing the way that policy was implemented in Harare. And so I think an important lesson from this is that we have to be able to communicate these findings to an audience in a way that builds that trust, builds that confidence that the science can really help inform things to be better in the future for precision medicine. I'll give you then where Colin's team has moved forward in 2025. This is a review that they published recently in annual reviews about pharmacogenomics in Africa and its continued potential catalysis for precision medicine. And I'll draw your attention over onto the left side of the screen in that lovely color map. A lot of genes that are listed there, but pay attention actually on the right side, because you'll see a red and a blue color. And the blue colors show where the variation in genetic differences really don't have a big effect on the standard dose of the guidelines that would be used for dosing a medication effectively. And the medications are listed on the far left side. But the red lines actually do indicate where there is significant impact. And so you can see right away there are a number of medications, efavirenz being one, sertraline being another one, and then also PEG interferon and ribavirin therapy that are really have different characteristics in their metabolism and their pharmacokinetics in African populations, and that needs to be considered. And importantly, to remember, and I'm sure I don't need to tell this audience that Africa has a huge amount of diversity across the continent. As you see on the right, these are then different variations in metabolizing enzymes based on different countries and the data that was sampled from those countries. And so really understanding this variation and its potential for altering the appropriate dose in patients and being able to dose patients effectively and significantly is a key thing for moving drugs forward in the continent that can actually have impact. And importantly, this most recently was published in a study that was done to explore the effect of tamoxifen metabolism in Black South African women and its impact across Black women in the continent. And here you see a news article that was actually published as a complement to this article in Nature Africa, noting that increasing the dose of tamoxifen would be important to increase the effectiveness and get better breast cancer outcomes for Black patients. And so these key pieces of information, the science that many of you are participating in and developing, really important to be able to communicate effectively to the populations that you're serving so that people can understand the impact and know and understand the differences that exist within your own populations, as Catriona referred to earlier in her talk. And it's not just Colin's group that's doing that, right? This is actually a number of publications that I just sort of grabbed as fast as I could off of PubMed. And I'll confess that many of them were chosen because I think some of you are in the room that are there. So if you see your paper, that's great. I think one of the things that's really critical is that this is expanding as you see the population of pharmacometricians start to grow and blossom across the continent. There's a lot of information and a lot of data that's being generated, and we need to use this information in an effective way. And it's incumbent on us as pharmacometricians to be able to communicate the importance of these differences. So as Catriona referred to earlier, we don't view it as one dose for everyone, but actually really take advantage of the science to move this field forward, perhaps in a way even faster than what you see in other regions of the world, my own included. So the second part that I want to talk about is, the second need is this communication. And it's important that we communicate what we know, which we just talked about from Colin's own example with genetic variation and its impact on drug metabolism. Also really important to communicate what we don't know. So here is a graph, again, from that same annual review paper that I just talked about. And it's really interesting to look at the top graph and see the number of publications that are referenced in the pharmacogenomics library that's at PharmGBK based out of Stanford. And you see the publications that include African populations is just a very scant red line that only starts to appear maybe as early as 2005 and then has very little increase over the next 10 to 15 or 20 years. And so the important thing to think about is if people start to get excited about the potential for AI, if AI is being used and developed off of literature that exists that's heavily weighted in non-African populations, its opportunity to actually help predict what is likely to be important for African populations is going to be quite limited. So I think we have to really keep that in mind as we start going forward and experience and explore the use of AI tools as a way to essentially improve the ability to get towards personalized medicine. And I think it's important that you as African scientists remind the world of this shortcoming and tell that story and start to build the data and the knowledge from the data your own collecting. And I put over on the right side something that I listed as Shirley's maxim. This comes from a colleague that I've had the great pleasure of working with, Dr. Shirley Malcolm, who used to be a director in the United States National Science Foundation. And she had a simple story that or a line she would say, that is, tell your own story or someone else will. And so it's important that African scientists tell that story that's critical for African medicines to be delivered effectively to African populations. And you as pharmacometricians have a really intricate understanding of those variations and their importance in clinical medicine. And I think that's just an incumbent thing that we need to always keep in front of mind. It's important also to tell a story that your other colleagues can hear. So too often, right, in the room that you're in, you can speak as the scientist is doing on the left side, where she's talking about the drug half-life and the bioavailability in its two-compartment model. But too often, your colleagues on the right side of the screen have the reaction that we're seeing with this gentleman in the green shirt, right? And so it's great to be able to be among your peers and speak in a language that you can all really understand. But when you go outside of that room and you have to explain the importance of your work, it's really critical to be able to use terms and speak in a way that's relevant to the person you're trying to communicate with, or they really can't hear you. And I don't mean that, they can't hear your words, they just can't understand that. And I did a real interesting example, just again, because Colin asked me to be a futurist as best as I could in this talk. So I started to involve a few of the AI chat engines that are available. So I asked Claude, which is run by Anthropic, to give me a dialogue for when a pharmacokinetic scientist talks to a normal person. And what Claude produced is this picture you see here. And the key thing is, if it doesn't inform, then it's not communicated. And I thought it was really interesting that the AI chatbot was able to very quickly discern that the PK scientist could talk in a huge amount of detail with a huge amount of variables. And the average citizen is left confused because they just want some basic answers like, should I take my medicine with food? How many pills do I take? Once a day, twice a day? Will it make me dizzy? And can I drive to work? And importantly, this translation that's needed. In this example, the scientist used 15 technical terms to basically say the simple phrase, your medicine peaks in your blood after 2.5 hours, lasts about 7 hours, you should take it twice daily, right? So really being able to distill the key elements of our insights into the things that the people we're trying to communicate need to know how they can use our information and our knowledge effectively, I think is really key. And one of the things I would encourage you to do is when you're looking at the posters, look at the posters and see if they tell you what's the relevance of the work that they did, right? Is it about showing that I have better numerical precision, or it actually helps me know how to dose this drug better for patients? Because we have to continue to get practiced at being able to say the so what, as it were, for our work, why this really matters and why that's important for people to listen and pay attention to us. And Catriona's group published this paper, which I found really interesting and helpful, talking about consent. And this is, again, where as pharmacometrician scientists and clinical scientists, when we talk to the population to involve them, it creates our opportunity to build that trust that I talked about so that they can understand, why are we doing this experiment that we want them to be involved in? What's in it for them? And what will be learned that will help not only them, but the community at large? And in this paper, there's a really nice presentation with these on the right-hand side with different pictures that talk about key things to remember, like making sure that you're translating your consent form into a local language and really simplify the complex. It's not that we're saying people are not clever enough to understand. It's just that they're not schooled in the language and they don't know what the importance of what we're doing is to themselves. And so it's really incumbent on us to make sure that we communicate that in an effective way so they understand what their contribution to the science is doing, not only for their own care, but for those that will follow afterwards. So I really encourage you to focus heavily on language and communication. It's not a skill that scientists typically spend a lot of time on. We spend much more time on statistics and numerical precision. I would say that being able to have grammatical precision is as important, if not more important, than numerical precision and really tight confidence intervals in your PK model. So last, I'm going to talk about the implementation part. And I do that with this caveat. I've used this slide in talks since Colin Pillai has probably seen it 5 times since 2004, because I really it really spoke to me. So this is a picture of a computer. It's not the one I was talking about in 1970, right? This is from the RAND Corporation. It's a US corporation that does a lot of strategic thinking. And this was their perception in 1954 of what a home computer would look like in 2004. And so, this just gives you all the caveats and the shortcomings of our ability to think really creatively about what the future might hold. I just love this picture with all the dials, and the home computer has this really unique feature of a teletype, right? Imagine sitting that in your own living room right now and trying to work on a computer to do that. The other thing I never have figured out is, what is that giant steering wheel thing on the left side of the computer, right? So, just really fascinating how we can't look beyond our own space to project what the future is going to look like. We certainly couldn't do that at the RAND Corporation. And I would say that if this is what computers looked like in 2004, we'd all still be probably using slide rules. So, I bring that up as a caveat as I go forward. But importantly, this document called Pharma 2020 was created in 2008 with a hope for the future. And in the bottom left corner, you can see the link for this document. And I think the slides will be available, but if anyone needs access to them, I'm happy to share them. This was produced by the consulting firm PricewaterhouseCoopers, or PwC, and they really started to estimate what is the potential of what drug development might look like virtually in 2020. And the picture is supposed to indicate the digitization of human health so that we can really understand in very quantitative terms how biology is functioning, how it responds to new therapeutics, and how we might be able to treat people with their own personalized medicine in the future. And so one of the things that they really made a contrast of is the current development process at that time, which I'll tell you right now, at least in the US and in Europe, has not really changed significantly. So it was 8 years to go from the phase 1 actually to a submission document into a regulatory authority. And that would be a drug that actually didn't stumble or have any problems along the way. And you see a lot of terminology here, but importantly, what they thought the process might look like is going from 8 years down to 1.5 years. And why was that? Because there's a lot of knowledge on the front end of development that we can build off of and not have to start from scratch all the time, and use that to justify and complement the data that we learn as we take drugs and new therapeutics into humans and essentially assess their impact. So the idea was that you could contract this dramatically if we can harness this knowledge down to as little as 1.5 years and have a limited clinical use, right? So focus a place where the drug can have its best impact and then learn and adapt over time as it starts to expand beyond that first limited clinical use. So this was actually building off of what the US FDA had really started in the early 2000s of using model-informed drug development, MIDD, which is a term you'll hear and you all know probably pretty well. But the idea and the promise was that this was going to allow us to really accelerate the development process. And unfortunately, we're not there, and we haven't gotten there. And the reason we haven't gotten there is many-fold. I think part of it is just a bit of how hard it is to change a paradigm when you're building from a continuum. And so to that, I think it was fascinating to see this other figure, which talked about what the regulatory process could look like. And I put this up because I look at this and think this could be an interesting model for Africa and the new emerging AMA to consider. And here you see essentially that 1.5 year development process on the left and clinical use going into a number of countries, and then followed by a series of 1.5 year development cycles as indications expand. There are many therapeutics that are approved right now in Europe and in the US and other parts of the world that aren't available in Africa. And there's really probably no reason that they need to go through an 8-year process as they did to get their original approval to actually be effectively and efficiently used in Africa. I think the data and the knowledge and the insights and the clinical capability exists, some of which is sitting right there in the room. And if we can harness that, we can start to realize this kind of turnaround rate in a place like Africa and start to actually get to this dream of a much accelerated drug development process. So one of the key components of that is potentially AI. And I want to caveat that because I'll say the FDA and the EMA couldn't implement this goal of reaching Pharma 2020 in a shortened timeline. But maybe AI can help the AMA, the African Medicines Association, realize this prediction in this rate. And in this case, I'm using AI not to mean artificial intelligence. I actually don't like that term. I don't think it makes a whole lot of sense, in all honesty. I'm using it to mean automated intelligence or amplified intelligence. And in automated intelligence, there's a number of things that we could implement in regulatory review of drug development that could be automated, turned over to machines, and more efficiently and effectively handled. That includes dossier review, some quantitative validation of the data in the submission to make sure that the numbers actually make sense in both a physiological and numerical way, and then just necessary routine processes that have to be followed to make sure that we have a quality package in front of us. The other place where I think is incredible is the amplified intelligence. That is the comparative inference that you can get from using these new AI tools, the clinical impact prediction, or the estimated lives saved. Putting that information together, you can start to then amplify the capability of all of you sitting in the room, not replace it, not to actually supplement it, but actually to amplify what you already know and use it as a way for synergy of your own knowledge. And these principles then of model-informed drug development really make this idea, I think, plausible for the future. And this is where pharmacometricians can help make this real. To not look at AI as some black box mystery that allows us to actually get our non-mem runs to converge faster. That's not actually the potential. The potential is leveraging our knowledge base and really starting to actually rapidly be able to integrate the information for impact in patient care. And it was fascinating to me, when people talked about the 2020 meeting, 2022 meeting that was in Cape Town, there was a side meeting with regulators, particularly from SAFRA for a number of countries in Africa and the US FDA. And it was interesting when you listen to the stories and the experiences exchanged across the regulators, what you could easily see is that every regulatory agency had to create a great bench of talent. And the thing that I thought differentiated the US FDA from the other regulatory agencies, they just had more people. They had a bigger team, but they weren't any smarter. They just had more smarter people. And so what AI has the opportunity is to take resources that exist in your own country, in your own teams, in your own clinical experiences, and amplify them so that you don't need to have 20 people to do the work. You can actually do it with a fewer number of people because you're amplifying the knowledge that they already have. So again, not replacing, but really essentially augmenting and expanding on that capability. So then, because Colin challenged me to be futuristic, I employed chatbot Claude again to ask and give me an insight on what our field might look like 100 years from now. So this is the dialogue. I pasted it right into the slide. And I asked, I say, hey, Claude, can you reimagine my business as if it were founded 100 years in the future? And then I told Claude, my business is optimizing the process of drug development based on quantitative modeling and simulation of drug dose-effect relationships so that developers can determine the optimal dose of a new therapeutic for a population of patients. And Claude wrote back, perfect. That's a fascinating field that will definitely evolve dramatically over the next century. And then I gave Claude a little bit more information and said, and I'm working almost exclusively on underserved communicable infectious diseases like tuberculosis, malaria, parasitic infections. But of course, that was shortchanging it because, as Catriona said, we also have to worry about type 2 diabetes, hypertension, and a number of other conditions as well. And what Claude came up with was a vision that essentially it's listed below there, but I'll show you in the bigger package, something that was called the Global Pathogen Defense Initiative. And this transformation that Claude is predicting in 100 years is pretty bold. But actually, I think it's not all implausible if we dare to dream, right? So one thing in particular, TB treatment goes from 6 to 24 months down to 14 days with AI optimized dosing. I actually asked Claude, really? You really think 14 days? Is that going to make sense? And he came back and said, well, maybe that's a bit optimistic. But then again, if you think about most bacterial infections are treated with a 14-day course. And so the challenge we have with TB is that the drugs we use to treat the pathogen oftentimes don't get to the pathogen effectively. And so they're not, we have to relatively maximally overdose these drugs to be able to treat the pathogen in place. If we can get better drugs to penetrate TB lesions, to actually diagnose disease earlier, all of things that are really making great strides these days, that this opportunity to turn it down to days rather than months, I don't think is that far-fetched. The malaria deaths could drop from 600,000 plus to under 50 annually. Wow, that would be phenomenal, right? That's not going to happen solely by therapeutics. It's going to happen by a number of factors together. But certainly being able to effectively detect and treat malaria will go a long way towards that. And I love this thinking of 2.4 million autonomous treatment pods bringing personalized care to the most remote locations, right? We're already seeing in places like Rwanda where drones are being used to deliver medication, same in Madagascar, right, to remote places. Those aren't autonomous pods, but again, not hard to start to think about 100 years from now, what might the technology be if we can enable it by combining the knowledge and the insight we have to improve clinical treatment for patients. And then real-time resistance prediction also prevents drug resistance before it develops. Coupling this and partnering with our epidemiological modelers to understand where we have to adapt our strategy based on emerging resistance. But I think it would be tremendous if we could all manage to say that pharmacometrics becomes the foundation for eliminating humanity's oldest killers. So that would be a tremendous outcome. And this optimism of where we could go, I think is actually within our realm and within our capability. And how can we do this, especially with partnership with the African Medicines Association, as they come on board and start to really accelerate the ability of medicines to be available across the continent? How do we help them leverage this knowledge for good and for that dream that was envisioned in 2008, which is actually very doable? I think it just requires the will and the capability of people behind it. And there's a lot of effort that's already going on. I know I'm not saying anything that's unique that other people haven't thought of as well. And so I'll finish with just this recent article from Kelly Chaba and team that was in CPT about their approach to model-informed approaches to optimizing therapeutics in the African patient population. And here you see a flow chart that Kelly starts to outline about how the work in his H3D group in Cape Town is starting to think about individualized therapy for patients based also on not only on their own physiology, but also concomitant disease and other conditions that they have going on. So this is thinking that is happening all around you. It's happening in your colleagues sitting to your left and your right. And what we need is a collective momentum to bring this forward as a group and have it done within Africa for African conditions by African populations to help African citizens in the future. I think the capability is there. A large part of it sits in the room. And I would love to be able to say, we helped catalyze and move this forward and see you succeed at that role. So that's my big push for the future. The opportunities created, your science builds trust in the community and across your scientific peers. Pharmacometrics can clearly inform and people understand the insight and the knowledge that's gained from it. And that implementation doesn't replace, but amplifies the intelligence that's sitting right now to your left and your right and in your own self as you think about the new opportunities going forward. So I'll leave it at that and say, let's realize this future. And thanks for the time and the opportunity to speak.
Steve, that was amazing. As is customary with keynote presentations, we're not going to take questions. So Steve's brief was that he would stimulate us, he would challenge us, and he would also put some controversial things there. Now, I found one controversial item, I'm going to take the chairman's privilege to actually call it out. You spoke about Kelly Chabale's paper, but Mwila is in the room or at this conference now. Mwila, on behalf of Steve, apologies that he called it Kelly's paper, not your paper with Kelly.
Well, I did say it was from Kelly's group. I didn't say it was Kelly's paper. So there you go. And in all honesty, I wasn't sure I could pronounce Mwila's name effectively. So that's why I said Kelly's group. Okay, so.
Steve,
but
good recovery. What we asked Steve to do was to put out those thoughts there, and that for us to start thinking about it over the rest of the day. And what will happen at the end of the day is that we'll have a panel discussion. You've already seen Steve's colleague, Dan Hartman, comment in the chat. So those of you that are online. So Dan will facilitate that last session. And during the course of the day, Aida is going to help Dan to pull some thoughts together in terms of figuring out what do we use Steve's presentation on to take us to the next level, to take us beyond this conference. Steve, we'll let you get some sleep, but it would be really great if you could join us again when we have that panel discussion. So that's where we are. Steve?
I told Vaishni that the panel discussion starts just about the time I get back from the gym in the morning. So happy to join.
Awesome. So Vaishni and I just want to tell you one more thing. That's a time-bound item. We already started to introduce that just before Steve's presentation. And that's the delegate's choice. Vaishni, do you want to take it? You want me to do it?
You can go ahead, Colin.
Okay, so we're going to project a QR code right now. If you scan that code, it will take you to delegate's choice or people's choice. So all of the posters, the virtual and the online, the virtual posters, as well as the people that are in the room, this is your opportunity to vote. So you can vote on whatever criteria you want to. There are some criteria that are listed when you click that link. If there's any issues with the link, let us know right now. Put it into the chat or in the room here. Just find one of us and we'll fix it. Vote once. You can vote for your friend. You can vote for whatever. But this is the people's choice. This will complement the choice made by the experts. Now, the issue about here is that we want to be able to analyze the results. So this is time-bound. There will be a poster session, a live poster session a little bit later in the afternoon, but we need to close this delegate's choice by about midday Kampala time, So we'll remind you periodically as we go through the meeting. So go online, take a look, and vote for your best poster. Vaishni, did I cover that okay?
Yes, you did perfectly. Thanks, Colin.
Cool. And then we're going to give it back to Babatunde in the room. But first, there's another video message that we'd like to show you.
I want to begin by expressing how genuinely disappointed I am not to be able to be there in person with you all in Kampala this morning. There's truly no substitute for the energy, the enthusiasm and collaboration that can happen when there are so many of us in the same room at the same time, especially at an event as noteworthy as this one. I'd nonetheless like to thank the organisers for allowing me to record this short greeting, and if all's gone according to plan, I should have been able to join virtually. For those who don't know me, I've spent the last 25 years working as a pharmacometrician. I started off doing a PhD in the PK of tuberculosis drugs at the University of Cape Town. Spent a bit of time as a postdoc at Uppsala University before moving to Novartis and Exprimo, and eventually formed Occams with a small group of my colleagues about a decade ago. Along the way, I've been fortunate enough to be part of the PAGE Organising Committee, a member of the Board of Directors of the International Society of Pharmacometrics, as well as its president, and a member of the development team behind NLMixR2, a nonlinear mixed effects modelling tool that hopefully many of you are already familiar with. One of the perks of being a consultant and volunteer in some of these organizations is that I've been able to collaborate with many brilliant colleagues, some of whom I see are present at this meeting. It is truly inspiring to see how much the field of pharmacometrics has developed in Africa since my early days as a PhD student in Cape Town. When I started out, we had to build our own servers based only on a pile of yellow manuals, the NM users mailing list, and weekly conversations with faraway advisors. I'm not exaggerating when I say that there was a cheer in the office the day that we got non-mem to run successfully for the first time. This is a far cry from the thriving world-class pharmacometrics research groups that have grown up at Cape Town and elsewhere around the continent in the intervening years. I'm very proud to have been there at the very beginning, and even prouder to see what pharmacometrics in Africa has become, culminating in today's inaugural Pharmacometrics Africa conference. Today is important. Pharmacometrics in Africa has been mature for a while now, producing excellent and important work in areas that have traditionally been neglected. And although WCOP in Cape Town was a tremendous success at the tail end of the COVID-19 pandemic, today is the first time we're able to show our science at our own meeting. This means a lot. My congratulations to the organizers for bringing us here today, and I trust this meeting will not only be a great success, but the first of many. Thank you all for listening, and I hope to see you in person next time.
We all agree with me that they're exciting since. So in the next part of this session, we hear from Dr. Aida Kawuma. She's a scientist at Puma AI. Dr. Kawuma is a trained pharmacist from Makerere University, and she holds a PhD in pharmacometrics from the University of Cape Town. She's a member of the Make Center Modern Group and the Uganda chapter of Pharmacometrics Africa. Here today, she brings a wealth of experience in pharmacometrics, applying her analytical skills to a wide range of drugs to optimize treatments. Later on, Dr. Eliford Gitabi from Tanzania and presently in Food and Drug Administration in USA will join us virtually. He has over a decade experience in clinical pharmacology research and is currently serving as the lead in cardiovascular safety reviews in the Office of Clinical Pharmacology in FDA. He's also passionate about using innovative mathematical modeling and simulation to improve drug development and therapy. And lastly, Chaba, an assistant professional researcher at the University of California, will join us virtually also. She's about statistician with specialization in early stage tuberculosis drug developments, and she will join us virtually to contribute to this session. Thank you. Now to you, Aida.
Thank you very much. And it's an absolute pleasure to take you through my talk this morning about careers in pharmacometrics without borders. And my name is Aida Kawuma. Okay, so first up, okay. My career in pharmacometrics starts here at Makerere University Medical School, where I enrolled for a degree in pharmacy. And I found that I really enjoyed pharmacology lessons. It was a 4-year degree. And after my graduation or at graduation, that's where the story of my laptop starts. So the first laptop I ever owned was a gift from my mom on graduation day. It was large, it was bulky, the kind which has a CD-ROM. It's possible that some of you don't even know what that is right now. Yeah. So, but instead of binge watching a series like Keeping Up with the Kardashians, I decided that I wanted to teach. So I volunteered at pharmacy school. It's right next door, actually. But then I soon realized that I couldn't get onto the payroll without a postgraduate degree. So having enjoyed pharmacology lessons, I decided to enroll for a master's degree. Now, at the same time, I began working as a clinical trial pharmacist. I got employment. So I worked as a trial pharmacist, working on double-blinded studies, randomized, and I also became a study coordinator. So that meant that I was gainfully employed and I was able to sponsor my own master's degree. But because the funding was really limited, there were very few options for my master's thesis. So I couldn't afford to buy HPLC columns for lab work. I couldn't afford to buy some of the reagents we use for different assays. And so the low-hanging fruit was to do something with rats or animal models, so plant concoctions, test something in rats. But I was not fond of rats at all. And also, I didn't want to come in over the weekend. So you can imagine if you were feeding rats something, or if you needed to test something, collect urine or something of that sort, you'd have to come in over the weekend. I was not willing to do that at all. The weekends were for hanging out, you're young and funky, just straight out of campus. So that was a no-no for me. But I still wanted to do something that was new, something that was novel, but on a budget, like I've said. So no plant research, no herbal research, no CAP studies, knowledge, attitudes, and practices. I wanted something new, but on a budget. Now, something serendipitous happened. We got at the tail end of my first year as a pharmacology master's student, we got a visit from Professor Ene and Joel Owen at that time. And these were well-established pharmacometricians. They gave, I think, either a 5-day or 4-day workshop on non-MEM, on pop PK modeling, and I was lost. By day 2, there was a lot of jargon, there was code, you had to learn to use non-MEM, there was R, but, sorry. But our head of department at that time had a data set lying around. It was a remnant from his PhD work. So he had a data set on efavirenz. We've been told about this new thing. And so that solved my problem. This was something new, like I wanted to do. No funding was needed. I had a laptop. You remember the laptop, the story of the laptop. That's why it's important. So I had a laptop, and this didn't involve rats. I didn't have to come in over the weekend, and I had clinical trial experience from my time as a trial pharmacist. So it was very easy for me to understand pharmacokinetic data and how it had been collected. And so that solved my problem. And so I decided for my master's thesis to actually do work on PK/PD modeling of efavirenz, looking at neuropsychiatric side effects during HIV treatment. And so at this point, I actually want to highlight the fact that as scientists, what you do or what you give back, those seemingly random lectures you give, those webinars you give, because if it wasn't for Ene and Joel Owen coming to Makerere University to give a 4-day workshop, I probably wouldn't be here. So I just wanted to point out that it's vitally important to give of your time, of your expertise, however small and inconsequential it might seem. So after that, during the time of my master's, we became aware of a call from Novartis Pharma. It was a call for PhD students. I wasn't a PhD student, but I was a go-getter, so I applied anyway. And I got in among the 20 scientists they needed from a low and middle-income country as one of those scientists. But it involved sacrifice. At the time, I was married and I had a 6-month-old baby. And I thought to myself, do I go, do I not go? But I had a very supportive husband and supportive parents. So they said, you know what, go for this opportunity. Leave your baby with us, we'll take care of your son. I often cried at night. I cried myself to sleep and second guessing myself. Are you a good mother? Are you a bad mother? How can you choose your career? That sort of thing. So I had lovely mentors throughout my 3 months at Novartis, Jean-Louis. I had Guillaume Bagné. I had Christophe Meiliu. So really, I did 3 months of internship at Novartis using monolix, but also most importantly, Colin Pillai was the convener and the group lead of this program at that time. So I met Colin Pillai, needless to say, he then linked me to Paolo Denti, and fast forward with funding from the Gates Foundation, I enrolled for a PhD in pharmacometrics at the University of Cape Town in 2019. Now, in 2020, I got pregnant with our second son. So on top of that, what Catriona mentioned, that you have a pregnant lady in all this environment, there was COVID in 2020. So I'm pregnant, there's COVID, and that's actually a picture of myself pregnant with my husband, with the son that I left at 6 months. I'm now back, and so he's with us. Yeah. So that's actually at the Ugandan consular office in Pretoria. We were waiting to be driven straight to the airport in Joburg and expatriated back to Uganda. And so I almost gave up. Needless to say, it was a very difficult time. Pregnant, COVID, second guessing yourself. And this is where a support structure is vitally important. I remember my big sis saying, just because something is difficult and it's going to take a little bit of time doesn't mean it's impossible. So I am happy that I didn't give up. I got to graduation day, and that's my supervisors, Paolo Denti and Roland. It really was worth it. Another serendipitous encounter, right at the tail end of my PhD, Catriona gets funding for a postdoc position here at IDI. And so as luck would have it, I'm Ugandan, and it's like Paolo just, from one mentor on to the next one. Yeah, so from Paolo, next to Catriona, I'm in the background in yellow. You'll see that's 2024, after I just had another son. So yeah, so we've achieved a lot together, I can say, as the Milk team. That was at the PPPK workshop in 2019. But also as a postdoc fellow, I had the opportunity to do the APT fellowship. And apologies. So that's just part of the Milk team, and I just want to call out that it's a tremendous team to work with. We've done things on community engagement. We've done work together with people living with disabilities. So it's such a good team to be part of. And as my postdoctor, I was able to join the APT fellowship and worked on industry kind data. My project involved developing a shiny app for monoclonal antibodies. That is the beginnings of the app, but the app is still being developed further, and hopefully one day it will be put to market. But that brings me to my role as a consultant, as my current career path. So I've been with Pumas AI for a little over a year now, where I consult with the scientific, strategic, and consulting services. So Pumas AI is a consultancy that is based and headquartered out of the US. And I'm just going to now give you a little bit about my work as a consultant at Pumas AI. We consult on a diverse area of disease areas, from oncology to rare diseases. So I've worked with medication being developed for myelomas, to solid tumors, to really rare diseases. And I work across all stages of drug development, so from first in human data all the way to phase 3 data. But one thing I want to highlight is the fact that for consulting, it's a dynamic, fast-paced environment that is usually driven by the client. So oftentimes when the client comes to us, they have a specific question, they have a specific need, they want a POP-PK model, they want a PK-PD model, they want an exposure response analysis. So it's really dynamic, it's fast-paced, and it's driven by the client needs. And that means that you need to be adaptable and flexible, because sometimes a client comes in and they want to submit a briefing book to the FDA within a month, and they want to include something, and therefore you have to be able to be flexible. As something that has not been that I cannot overemphasize is the need to communicate well. Oftentimes you have clients who know exactly what they want, but then sometimes you have clients who have only a clue about what they want, so they are not really sure about what they want. And they're depending on your expertise and your sort of guidance to say, this is a better analysis than that analysis, and this is the reason why. You can make this claim with your data, but you cannot make that claim with that data. You need something more. So you have to be able to communicate very well your decisions and why you're doing what you're doing in a clear manner. So something else that I want to say for Pumas AI is that it allows for 100% remote work. So even though we're headquartered in the US, I work from home, I work from Uganda. I have flexible hours, and that is a model that allows me to remain local and therefore remain relevant and I'm still able to help in shaping the future of pharmacometrics in Uganda and in Africa. So we still actively involved in the Milk Center here at IDI, supervising students, but that is only possible because of the flexibility of the work hours and because I can remain on the continent and yet contribute to world-class research. Okay, it's working. So I want to say, as I begin to close, I just want to say the journey of a pharmacometrician, it will be different for everyone. So I came in through the side of pharmacy, and for me, really what drove me in the very beginning was the fact that I didn't have funds to fund my master's, another thesis program, another a different thesis area. So it will be different from everyone. You might be here and you're a statistician. You can come in from that angle. You might be here and you're a mathematician. It's different for everyone. But I also want to say that oftentimes it requires sacrifice because the discipline is now it's becoming more established, but when I started, it wasn't. You will definitely have to travel. We've had to travel to Cape Town, Uppsala Summer School for the page meetings, for A-Corp, for W-Corp. So it almost always requires sacrifice on your part. My 6-month-old son who I left is now 8 years and he's thriving, but it was a sacrifice at the time. And also want to say that it's not always obvious or the first choice. But if you're unsure, test the waters. I remember doing a 2-week course on epidemiological modeling in Johannesburg, and then I realized, no, it's not what I want to do. So test the waters and see if it's something you're interested in or if it's something you're not interested in. Network. The reason I shared my story is that you will see along the way, I am not self-made. I've stood on the shoulders of the people who came and gave a 2-week training, someone else who, like Colin, someone else who, you know, funded you here or there. So network. You cannot go it alone. And those seemingly serendipitous moments were all driven by people. Our support structure goes a long way. I cannot tell you how many times I wanted to quit with a PhD. But having a spouse and having a family, that it could be a sibling, it could be a colleague, anyone, having a support structure does go a long way. And then also lastly, in the field of pharmacometrics, you have to be teachable. As the motto is live and learn. You know, the thing with pharmacometrics is that we borrow from so many disciplines. And so when AI changes, the way we do pharmacometric models will change. When statistics changes, the way we look at our models change. When a new, you know, so when our understanding of genetics, of phenotypes changes, the way we do pharmacometrics will change. Something that originally wasn't important as a covariate, if we have more information on it, it's then going to become important in our field. So I think some of the ingredients that are essentially really important for our journey as pharmacometricians is to be teachable and to want to learn every single time. Lastly, I just want to summarize, some of these will come out in the talk with Eliford and Linda, but really the careers are a number. There are careers in pharma. I told you about my time at Novartis. These are just other examples of drug companies that have pharmacometric groups. It's in no way extensive. This is just an example. There are careers in pharma. There can be careers in academia, University of Cape Town. We've talked about Uppsala, now Makerere University, UCSF, where Samir is. Oftentimes, academia moves hand in hand with clinical care and research. So there are groups doing personalized medicine, therapeutic drug monitoring, clinical trial optimization. Also, there are careers in consultancy, like myself. At Pumas AI, we've just heard from Justin, who's at Occam's. There's representation here from Satara, from Prometheus. So the consultancy space is another area that you can go into. Then there are careers in the regulatory space. You're going to hear from Eliford at the FDA. There are careers in the EMA, the Japanese Regulatory Authority, and also so many not-for-profits like MMV. And as I close, I'd like to acknowledge some of the people who have helped me along my pharmacometrics journey. This list is in no way extensive, but trust me, each and every one of them have played a significant role. And lastly, but definitely not least, I would not be here without my family. And without my husband, Moses, if you look at the picture on the extreme right, those are times I've been away and he's been with our boys. So we have 3 boys. In the middle is the sacrifice baby. Where is he? The eldest holding his young brother. That's Emmanuel, the sacrifice baby that I left and then came back to. But they understand my work. They understand that I work mostly from home, mostly remotely. They are aware that if mommy says she's going into a meeting, an online meeting, everything has to wait. No noise, until she's done with her meeting. So with that, I'd like to say that I think I'm having my cake and eating it. Thank you.
Hi, good afternoon, everybody. My name is Eliford Gitabi. I am a pharmacometrician at the US FDA. My journey in pharmacometrics started with researching drug-drug interaction between antituberculosis and anti-HIV. During my PhD project, we collected pharmacokinetic, patient demographics, clinical characteristics, and treatment outcome data that had to be analyzed using pharmacometric methods. As a PhD student, I had to learn appropriate data analysis method, including pharmacometrics. Luckily, I was one of few students from Africa who were selected for industrial internship training in pharmacometrics at the Novartis pharmaceutical company in Basel, Switzerland. After internship, I analyzed my research data. And after graduating my PhD, I analyzed clinical research data for several other PhDs and master's students. Then, I was hired for postdoctoral research at the University of Maryland, Baltimore in the United States. At the end of 3 years of my postdoctoral research project in 2018, I was hired by the US FDA. My presentation today is about the laws of pharmacometrics at the United States Food and Drug Administration. I would like to begin with a disclaimer that this presentation reflects my views and should not be construed to represent the views of the FDA or the US government. Pharmacometrics is an integral part of the drug development process, as pharmacometric evidence supports decisions at various stages of drug development and drug regulatory reviews. Pharmacometricians conduct evaluation of drug development regulatory questions using quantitative approaches that integrates knowledge of drug pharmacology, knowledge of disease pathophysiology, knowledge of patient factors, and clinical trial characteristics to provide supportive evidence for decision making. This figure provides an example of stages in drug development where pharmacometrics analysis are conducted. This is an illustrative example which is based on a previously proposed knowledge management system in antiviral drug development. Discovery of antiviral drugs begins with the in vitro assay where a multitude of compounds are tested against druggable viral targets. Subsequently, the selected drug candidates undergo animal and clinical monotherapy trials. These include pharmacokinetic studies in animals and in humans, and the pharmacodynamic trials in animals and in humans. The knowledge that's obtained in these trials, the drug pharmacology that's obtained in these trials, is integrated with knowledge of disease pathogenesis to select candidate combination therapy that is tested in the phase 2 studies. So that knowledge obtained during monotherapy trials and animal trials is analyzed using pharmacometric method, and clinical trial simulations are conducted to select doses and combination therapies that are tested in the phase 2 trials. And then data that is obtained in phase 2 trials together with that previous data is integrated in another pharmacometric analysis and clinical trial simulation to select the study design and dosages that are further tested for confirmation in phase 3 pivotal trials. This slide lists some of the pharmacometric activities at the FDA. Pharmacometricians at the FDA mainly conduct reviews and research activities. Review roles include evaluation of drug applicant pharmacometrics report. This often involves repeating applicant's pharmacometric analysis. In addition, pharmacometricians may conduct independent pharmacometric analysis to answer specific regulatory questions. Some of the specific regulatory questions that are evaluated by pharmacometricians include, for example, whether there is exposure-response relationship to provide confirmatory evidence of efficacy or safety, and whether the applicant's proposed dosing regimen is optimal, and whether the proposed labeling information is supported by the data that the applicant has submitted. Pharmacometricians at the FDA may also evaluate clinical trial designs. This is achieved by leveraging prior information about diseases and pharmacology of existing drugs to propose optimal trial design. Examples of previous pharmacometric activities at the FDA have been published, and these include publication by Lee et al., who published the impact of pharmacometrics analysis on new drug approval and labeling decisions. The other activities conducted by the FDA, including research laws, for example, FDA may conduct research on developing quantitative models of diseases to answer drug development questions. They may also develop drug disease models for evaluation of combination therapies. And they may also develop physiological-based pharmacokinetic models for in silico evaluation of intrinsic and extrinsic factors. To the right here are examples of research activities that FDA pharmacometricians have conducted. Yi et al. Has recently published about the model-informed drug development approaches to assist drug development during COVID-19 pandemic. Zinyuan et al. Published about anti-SARS-CoV-2 drugs repurposing database prepared by the FDA. I will now present some specific case examples of pharmacometrics analysis at the FDA. This first example is a contribution of FDA pharmacometric analysis in selecting optimal loading dose of injectable Sotalol. Sotalol is indicated for treatment of ventricular arrhythmia. However, when there is overdose, Sotalol causes even more arrhythmia, which are life-threatening and may cause death. Therefore, there is a boxed warning that recommends initiating and increasing doses of Sotalol in a facility that provides continuous ECG monitoring. ECG should be monitored until pharmacokinetic steady state is reached, and this may take up to 3 days for a steady state of Sotalol to be reached. Therefore, the applicant proposed a loading dose modality where steady state levels would be reached at the end of infusion, and therefore reduce the duration of hospital stay when initiating Sotalol treatment or up-titrating Sotalol doses to higher doses. Pharmacokinetic and concentration QT modeling and simulation enabled selection of optimal injectable loading dose and determination of duration since end of infusion and to initiation of oral maintenance dose. This table represents the dosage of Sotalol in normal renal function, and this figure illustrates Sotalol pharmacokinetic profile and ECG monitoring activities during Sotalol loading and maintenance doses. FDA pharmacometrics analysis determined that injectable Sotalol should be infused for the duration of 1 hour with ECG monitoring, and the first oral dose, maintenance dose of Sotalol should be initiated 4 hours after end of infusion, and the dosing interval for the maintenance dose in normal kidney function should be 12 hours. In this slide, I will present research conducted by FDA pharmacometrician as a case example. This article by Yi and other FDA pharmacometrician summarize some of examples of model-informed drug development approaches to assisting drug development in the COVID-19 pandemic. One of the types of research conducted was to understand the potential of candidate compound in treatment of COVID-19. For example, FDA pharmacometric bridging was useful in accepting the proposed dosage regimen of remdesivir for emergency use. In addition, FDA pharmacometric analysis indicated that the safe oral dose of hydroxychloroquine for effective treatment of COVID-19 was not achievable. For those who remember, hydroxychloroquine was proposed as a potential treatment for COVID-19, but it was its emergency use authorization was later revoked. And this was following research that indicated that the dose that would achieve effective cure of COVID-19 would also have some significant side effects. So it was not achievable. Another research that was done by FDA pharmacometrician was evaluation of reduced dosage regimen of candidate drugs for COVID-19 in order to manage limited supply and also to manage drug resistance, manage emergence of drug resistance. For example, FDA pharmacometric analysis determined that reducing doses of baravinumab and etesevimab in limited drug supply would not impact efficacy of the combination therapy. Efficacy was also assured even for drug-resistant SARS-CoV-2 strains. Another analysis that was conducted by FDA pharmacometrician was pediatric extrapolation of efficacy for COVID-19 treatments. After some months of approval of some of the emergency use drugs for treatment of COVID-19, the question arose of whether those drugs could also be used for treatment of children. The pharmacokinetic, the physiological-based pharmacokinetic modeling was useful in selecting the dose of remdesivir for testing in children less than 12 years. And pediatric baricitinib dose was selected, and this was based on leveraging PK experience of the drug baricitinib in other indication, and also PBPK modeling, bridging pediatric to adult PK. So that's the end of my presentation about the law of pharmacometrics at the FDA. I'm sure now you know the different activities that we do, which include the review activities and research activities. For those who are interested in FDA pharmacometrics reviews, they can find them as they are published online. They are publicly available online at the website that's indicated in this slide. Thank you very much.
So you've seen two examples of careers. The third person is actually in the room right now. She's in California time, and has actually been awake all night. So she has a video to show. That's Linda Chaba's. Linda would has asked us to show her video after we go to tea break in order for you to get a bit of a bio break. In retrospect, this session is a little bit long, and I can see that people, including myself, want to get to the bathroom. Linda, do you want to say one or two words, and then you can take a rest, and we will get back. Yes, there we go, Linda.
All right. Thank you, Colin, and good afternoon, everyone. I didn't know I would stay awake up to now. That's the reason why I have the recording, and I really feel a little bit sleepy. So please forgive me for not doing this presentation live, but thank you all. Bye.
Very good. So thanks, Linda, and please have a rest now. And thank you so much for staying up. By the way, Linda is part of the organizing committee and has been actively working on the poster judging. And yeah, thank you, Linda. So let's go now to a break. I think that will bring us to being on time for tea. Let's remind you also about the posters, or Veshni, maybe you can do that.
Yes, sure.
Mhm.
Well,
Go ahead.
so if we could please remind everyone that you can grab your coffee and please make your way to the poster section. We would encourage you to view the posters. Remember, the deadline for the Delegates' Choice Award is actually after the second session. So now's your time. If you want to have a quick whiz through them, do so with your cup of coffee. Thanks, Colin.
Thanks, Veshni. And then when we come back after the break, we'll show Linda's video, and then Babatunde will officially close the first session. Thanks very much, and see you. Can somebody just help me with the time? What time do we get back?
We should get back at 11:20.
Okay, so that's 20 minutes past the hour. Since we have people from different time zones, it's 20 minutes past the hour. For those of you that are online, Dina, will the session stay open? So for those of you that are online, we will close the session. You will be put into the lobby. You'll probably be a little bit lonely there. I will come there for a short while, but you can then take a break and come back and log in again into the system at 20 minutes past the hour. So thanks, everybody, and talk to you soon.